Good evening, dear doctors. I'll be talking to you about some respiratory diseases. I've been asked to cover certain topics. I'll be talking about these particular diseases. The other topics will be covered by some other teacher. Um, these are topics from where questions are frequently asked, and there's a lot of information that I'll be presenting to you, but I will point out to you, like previous classes, the specific questions that are asked usually, common questions that are asked from these topics. So you can note them down as I go on. Let's start with uh, acute respiratory distress syndrome. It's quite a common condition that we face, particularly when respiratory disease patients are deteriorating, especially in the ICU. This is a condition where a patient has acute respiratory failure characterized by hypoxemia. The patient has bilateral pulmonary infiltrates, and we must make sure that it is not due to heart failure. So this is the basic definition of acute respiratory distress syndrome. So this presence of hypoxia and bilateral pulmonary infiltrates is seen in heart failure, but the non-cardiogenic cases of bilateral pulmonary infiltrates are represented by acute respiratory distress syndrome. The most common cause, you must remember, is sepsis, and any primary lung disease like pneumonia or aspiration pneumonia or any inhaled toxins following trauma, shock, acute pancreatitis. These are the 4 or 5 common causes that can lead to bilateral pulmonary infiltration, but not involving the heart. There are certain set of criteria that you must follow. This is a very important slide. You get questions from this slide in the exam. The criteria for acute respiratory distress, it must be an acute onset. That means within 1 week of a known predisposing factor. Acute onset, number 1. Number 2, there must be bilateral pulmonary opacities on radiology, which is not explained by effusion or collapse. Number 3, there must be presence of hypoxemia, which is represented by partial pressure of oxygen or FiO2. It must be less than 300. Number 4, we must exclude heart failure. The pulmonary capillary wedge pressure must be less than 18. This PCWP, pulmonary capillary wedge pressure, it represents the left heart pressure or the left atrial pressure, which is usually increased in heart failure. So a patient ARDS must have a normal heart and normal PCWP, less than 18. So these 4 set of criteria must be fulfilled for labeling a patient as ARDS. And this is one of the important questions asked in the exam. So one question from one of these criteria. This is basically how ARDS looks like. You have a normal lung on one side and you have a fluid-filled lung on the other side, the fluid-filled alveoli. The basic mechanism is when you have a certain predisposing factor leading to release of inflammatory mediators. It could be sepsis, as I showed you. It could be pancreatitis. It could be pneumonia. Inflammatory mediators, they cause migration of neutrophils to the alveoli. These neutrophils, they release cytokines in the alveoli, causing alveolar epithelial damage and alveolar capillary damage. And there's a fluid accumulation in the alveoli and in between the alveoli and the capillaries. So there is impaired diffusion of oxygen. So this is the basic mechanism. The important question that you need to know from this pathogenesis is that there is diffuse alveolar damage. This is the thing that you have to know. And you do not need to remember the details of the phases of ARDS, but the question that usually comes is what is the main issue in ARDS? There is a formation of a hyaline. As I told you, there is exudation of fluid into the alveolar space, as we saw in the figure. There is a formation of the hyaline membrane due to protein-rich exudative fluid. This is called hyaline membrane. So this impairs the oxygen exchange at the alveolar level. This is the thing that causes the problem to the patient. So the fact that there is a hyaline membrane formation is an important thing you have to note down, and it's asked in the exam. So how does a patient present? So following a certain predisposing factor, a patient having acute dyspnea, cough, chest pain with presence of cyanosis, diffuse crackles on both sides, and tachypnea, will lead us to suspect ARDS. This is often asked, what is the state of the lungs in ARDS? Important point here is that the lungs become very low compliant. The PCWP is low, unlike in heart failure. So these are two important things you must remember, because this low compliant lung with increased risk elastic recoil, you must keep this in mind, because this is how, as we saw in the pathogenesis, that the formation of the exudate and the hyaline membrane within the alveoli and outside the alveoli, it impairs the diffusion of oxygen from the alveoli to the capillaries. So the alveolar oxygen concentration is normal. Present is a increased alveolar arterial oxygen gradient. The normal gradient is almost near zero. The same concentration of oxygen in the alveoli and in the arterial blood, pulmonary arterial blood, is diffusion, and there won't be any gradient in a normal patient. But in ARDS, through this impaired diffusion, the alveolar arterial oxygen gradient is increased. With ARDS, there is an increased alveolar arterial oxygen gradient. The bilateral pulmonary infiltrates, and almost similar X-ray is seen in cardiogenic pulmonary edema or heart failure. So it becomes important to differentiate. Regarding the treatment, you do not need to remember all these details. Basically, it's a patient to be admitted in the ICU has to be given a lot of oxygen, even non-invasive ventilation, and may even be needed to be intubated. And you have to treat the underlying cause as well. The basic thing about management is, what you have to remember is that, and another important thing is, sometimes you might be asked about what is the ventilator strategy that is employed in ARDS. The use of mechanical ventilator is a big chapter. You don't need to remember at this stage a lot of details. But regarding management of ARDS, sometimes you are asked what kind of settings might be employed in this situation. There is something called PEEP, positive end expiratory pressure, delivering the oxygen, and the tidal volume, PEEP sometimes, and the low tidal volume. Just remember these 2 points here. As you go on and see patients, and if you have to exposure, you understand the meaning of these terms. Just remember that the strategy used in you do not have to remember details of management and all that. So that was about ARDS. Please remember diagnosing ARDS, the fact that the patient, and that we use high positive and expiratory pressure and low tidal volume ventilation. And also remember the predisposing factors for ARDS. These causes are commonly mentioned in the textbook. One of the other causes that's recently come up recent times, although here I have mentioned pneumonia, any sort of pneumonia, COVID pneumonia. So you might also be having that scenario in the exam. It was a common complication of common predisposing factor for ARDS. So that's all about ARDS. We'll move on to bronchogenic carcinoma or lung cancer. As you all know, the most common predisposing factor for you're all familiar with this condition. I'll just point out to you certain important facts that are commonly asked. The previous risk factors for bronchogenic carcinoma. This is an important question that is asked in the exam. Obviously, smoking is a important risk factor, but this fact that a smoker has a 10 times increased risk of developing carcinoma, this is important. And patients with an exposure to asbestos, which we'll see later on, has a further 5 times increased risk of having bronchogenic carcinoma. So if a patient is a smoker and also has asbestos exposure both, so he has a 50 times risk of having bronchogenic carcinoma. So these facts are sometimes asked in the exam. Smoking 10 times increased risk, asbestosis 5 times more increased risk of cancer. A patient having a smoking history and both exposure to asbestosis, there's a 50 times increased risk of having lung cancer. And further, isocyanates seen in chemical workers, arsenic, radon, nickel. So sometimes these are asked in the exam. So you can go through this and remember this. Coal dust is not a risk factor. So this one's came in the exam, that which one is not a risk factor for lung cancer. Exposure to coal dust is not a risk factor. Okay. So lung cancer, there are basically two divisions, small cell and non-small cell. And non-small cell is the more common variety. It comprises of adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. This small cell carcinoma is very notorious because it metastasizes very rapidly. In most cases, uh, patient is already in advanced stage at the time of diagnosis. So it's very difficult to save a patient of small cell carcinoma or to diagnose the patient early. So let's go through some informations. Non-small cell lung cancers are more common variety. Um, the three subtypes are adenocarcinoma. It is what you need to remember about adenocarcinoma is when you have a question where a non-smoker is being mentioned and it's a female or a young male, more likely subtype of carcinoma you're dealing with is adenocarcinoma. So non-smoker, a female or a young male having a lung cancer is usually a adenocarcinoma, and usually the lesions are located in the periphery. So you have a normal bronchoscopy. Squamous cell carcinomas, usually central, more near the trachea and the bronchus. Usually they also have cavity. Large cell carcinoma, they are also peripheral lesions. So the adenocarcinoma and the large cell carcinomas are usually peripheral lesions, and the squamous cell carcinomas, even the small cell carcinomas, as we will see later, are central. So there is a small way to remember that squamous and small cell are central, both S, central, just to remember. Adenocarcinoma, large cell are peripheral. This is sometimes asked in the exam. They are located tumors like the squamous cell carcinomas, and they're very aggressive, metastasize in a short time, very poor prognosis, and survival is usually less than 1 year. So remember these things. Here are some few things that you can remember. Here are some is centrally placed, associated with smoking, might even cavitate. Adenocarcinomas are peripheral and more common in non-smokers and females. As we'll see later on, there is a subset of symptoms known as paraneoplastic syndromes. I'm sure you've all heard of it. The paraneoplastic syndromes associated with adenocarcinoma is clubbing, and with squamous cell carcinoma, it's hypercalcemia. We'll see a little bit more about paraneoplastic syndromes a little bit later on. So these are the few differences between non-small cell and small cell cancers. The non-small cell cancers are more common. They're the metastatic potential is less than the small cell cancers. Surgery is one of the options that can be used in non-small cell cancers, but in case of small cell cancers, they spread so rapidly that surgery is very rarely possible. And staging of non-small cell carcinomas is usually done in the traditional way, stage 1, 2, 3, 4. In case of small cell lung cancers, it is staged as limited and extensive. These are some of the differences you need to remember. So symptoms are pretty obvious. A patient with lung cancer will usually start with a cough, chest pain, hemoptysis, weight loss. If it's localized, that will be the symptoms. If it spreads, you will have symptoms of spread to surrounding areas like hoarseness of voice, dysphagia, superior vena cava obstruction, and you may even have metastatic features. So look at this question. If you have a rapidly progressive lung cancer with paraneoplastic syndromes, a likely diagnosis is small cell carcinoma. Squamous cell adenocarcinoma and non-small cell cancers, they spread very slowly. So if you have a patient having a very short period of symptoms, a likely diagnosis is small cell carcinoma. Like I said, there is a subset of symptoms called paraneoplastic syndromes. They are usually as a result of chemicals or antibodies secreted against the malignant cells or chemicals released by the malignant cells. Both non-small cell, small cell lungs are associated with paraneoplastic syndromes. I've put a box here down. This box is very important because you invariably get questions from this. So the paraneoplastic syndromes that you have to remember: with squamous cell carcinoma, the common paraneoplastic syndrome is hypercalcemia. You will have a patient with high levels of calcium. So you have a scenario where a lung cancer patient is having high calcium. You'll be asked what is the histologic variety of that cancer. You have to answer squamous cell carcinoma. Sometimes it is asked why this hypercalcemia occurs because of the release of a parathormone-like protein. Adenocarcinoma, patient will have clubbing or hypertrophic pulmonary osteoarthropathy. Small cell cancers, a lot of paraneoplastic syndromes. Commonly, we have to remember syndrome of inappropriate ADH secretion, Cushing syndrome, Eaton-Lambert syndrome, which is like myasthenia. So this table is very important. You usually get questions from this table mentioning where you need to remember the specific cell type associated with what specific paraneoplastic syndrome. Here I mentioned a little bit of details like hypercalcemia associated with squamous cell carcinoma, and the hormone responsible is parathormone-related protein. Hypertrophic pulmonary osteoarthropathy, clubbing associated with adenocarcinomas. In this condition, the patient has clubbed fingers and joint pain, symmetric polyarthritis. So read the question carefully. You will get the clue of this condition and you have to associate it with specific type of lung cancer. Here are a little bit of details about the paraneoplastic syndromes associated with small cell cancer. As I told you, I mentioned 3 paraneoplastic syndromes. One is SIAD, number 2 is Cushing syndrome, and number 3 is Lambert-Eaton syndrome. In syndrome of inappropriate ADH secretion, the patient will have low plasma serum osmolality and high urine osmolality. And the very important clue that will be given in the exam is the presence of hyponatremia. So when you have a scenario of a lung cancer with hyponatremia, your diagnosis is small cell carcinoma. This is very important and the most commonly asked question among all the paraneoplastic syndromes. So make sure you see the serum electrolytes and the sodium level given in your question. There will be a clue of hyponatremia, which will help you to diagnose the case. Okay. And the other 2 syndromes that I said, Cushing syndrome, where the typical presence of Cushing syndrome like the swollen face, hypertension, high sugar, hyperpigmentation, muscle weakness will be mentioned. And Lambert-Eaton syndrome is a syndrome which is similar to myasthenia gravis, where you have proximal muscle weakness, especially the thighs and the arms, and the cranial nerves and respiratory muscles are spared. Reflexes will be absent and there will be autonomic features. There is weakness and fatigability. And in compared to myasthenia gravis, there is increased muscle strength and negative response to tensilon, just opposite to myasthenia gravis. You will read a little bit more details of this condition in neuromedicine. So remember the paraneoplastic syndrome. This is a very favorite question for the examiners. It's commonly comes in the exam. And remember the hyponatremia associated with small cell cancer.
Sir,
Yes, please.
sir, can I ask one question,
Sure,
please?
sure, please. Yeah.
Sir, I am the in charge of this medical onco as a ICU team. So I have faced one problem during this lung cancer treatment. The patient
Yes.
was hypercalcemic and he was not treated with the bisphosphonate and the fluid management. And then the calcium level was around 11.2, 13.3 like that. And I have sent that vitamin D level and ionized parathyroid level. But the lung cancer, which kind of like stream is there, it was not diagnosed that biopsy has been sent. Then I have given the fluid management and I have tried the diuretics also. And then alendronate also they have given. Still the hypercalcemia was not settled. The next management, what should be the management, sir?
Actually, you have tried all the steps of hypercalcium management. But
Yes, sir, yes,
the
sir.
only thing left, you have to treat the underlying malignancy. Otherwise, you won't get the
They told
response.
her denosumab, sir,
Denosumab is
denosumab.
also having a role. That's right. That's
But
probably
as soon as we have given the denosumab, that patient end up into the hypocalcemia. It was a big trouble for us. Like then the sugar calcium was around 6.4 for 6.4, 6.8. And
yeah. You
yeah, this was the problem I faced during the treatment. I am already doing my DM critical care so final year, so I
okay?
want to learn from you the clinical things. And the second thing, sir, as you told that the small cell carcinoma, that there is an ACTH level increase, SIADH, and
Yes.
Lambert-Eaton myasthenia
Right.
gravis. That we
Right.
can diagnose with the serum. Sodium workup, we can diagnose the SIDH. Serum cortisol level, we can diagnose the
Yeah.
ACTH. How will suspect that the patient is in Lambert-Eaton myasthenia gravis? By autonomic symptoms only. Is there any test we can do and we can decide that the patient is in
Okay.
Lambert
I'm
Eaton
noting down your
myasthenia?
questions. I will answer all the questions at the end of the class. I'm just noting down the
Thank
question.
you, sir. Thank
Okay,
you.
I will note it down. Don't worry. Okay.
Oh,
So remember these paraneoplastic syndromes that I mentioned here. And now I'll come to the investigations that we have to do. Not a lot to remember from the investigations. I've just, for your interest, I have given you the possible X-ray findings that a patient may have. There are eight types of findings that a patient of lung cancer may present with. So I have labeled them here from 1 to 8. They have been labeled in this diagram. It may be a unilateral hilar enlargement. It may be a peripheral opacity, like number 2. It may be the collapse of the one particular lobe. There may be pleural effusion. There may be paratracheal lymphadenopathy. There may be pericardial effusion, raised diaphragm due to phrenic nerve palsy. There may be rib destruction. So there are 8 possible findings in a patient of lung cancer. This is for your interest. You might get a question from here. So usually we have to do a CT scan, usually for diagnosis, to determine the site of biopsy, and sometimes to stage the patient. Of course, to stage the patient, we have to do a CT scan. Confirmation is with biopsy. If it's a peripheral lesion, you do a CT guided biopsy, or sometimes an ultrasound guided biopsy. If it's a central lesion, you do an endobronchial ultrasound guided biopsy by doing a bronchoscopy. So depending on the location of the lesion, you go for the approach for the biopsy. PET scan, obviously, to know the stage of the disease and to assess the lymph nodes also, which is an important part of staging. Okay, so for management of lung cancers, you do not need to know a lot of this information. I have given you a summary of the management steps because questions do come from this table and management of lung cancer. Basically, when you manage lung cancer, the two things that will help you to manage lung cancer is the cell type. Is it a non-cell carcinoma or a small cell carcinoma? Number 2, the staging. So the treatment or management will depend on the type and the stage. So let's go with non-small cell carcinoma first. The non-small cell carcinoma, the treatment options if we stage the patient, if it is a stage 1 disease and a stage 2 disease, you can go for surgery. If it's stage 3, you can go for chemo plus radio. If it's stage 4, go for chemotherapy. Stage 4 means metastatic. Okay. So, and stage 3 means there is metastasis in one lung only and involvement of lymph nodes. And stage 1, 2, basically pretty much localized. So, depending on the stage, you answer surgery, chemo, radio, or only chemo. The most important question that is asked, that has come multiple times, what are the contraindications to surgery? Remember these four. If the FEV1 is less than 1.5 liter, and you have any evidence of metastasis, that is particularly vocal cord paralysis, malignant pleural effusion, and superior vena cava obstruction, in that case, you cannot refer the patient for surgery. This is a most common question asked from the management. So remember these four contraindications to surgery. In case of small cell carcinoma, like I said, the staging is not like the non-small cell carcinoma. Here we classify it as limited disease and extensive disease. If it's metastasized, it's extensive. If it hasn't, it's limited. Within limited disease, rarely there is an early stage diagnosis also, very rare to diagnose it early. That is the only time we can get a surgery done in small cell carcinoma, which is very rare. At best, you can diagnose a limited disease, in which case you give a cisplatin-based chemotherapy with radiotherapy, and the same management for extensive disease. The combination and the number of cycles is just increased, and the radiotherapy is different. But the basic treatment of a small cell carcinoma is chemotherapy with radiotherapy. As we know, the life expectancy prognosis is very poor for these patients, hardly 1 year at best. This is an emergency that is usually faced with these cancer patients. It is due to the compression of the superior vena cava associated with lung cancer and also with lymphoma. These are the two common causes of superior vena cava obstruction. The patient usually comes with facial swelling and a raised JVP, and it is an emergency. It is an oncological emergency. And the patient has breathlessness, conjunctival periorbital edema, visual disturbance, headache. And as I said, the JVP will be raised. If you do an immediate X-ray, you will see a widening of the mediastinum. If you get time, you can do a CT scan if the patient permits you to do that, but it's usually life-saving, and immediately you have to start the patient on dexamethasone IV to save the patient. And you may have a choice of doing a radiotherapy or doing a stenting later on to relieve the pressure symptoms. So, superior vena cava obstruction is associated with lymphoma and bronchogenic carcinoma, and the use of dexamethasone immediately, steroids immediately to manage the patient, and to do stenting according to the availability and the opportunity, and then radiotherapy later on. These are the treatment options of superior vena cava obstruction. This is another presentation of a lung cancer where the malignancy or the cancer is in the apex of the lungs, also called superior sulcus tumor. These are usually non-small cell carcinomas, and that place is anatomically important because a lot of structures are passing through that place. So a tumor in the apex might compress the sympathetic chain, might compress the recurrent laryngeal nerve, might compress the phrenic nerve, brachial plexus, brachiocephalic vein. So this tumor causing this type of compressive symptoms is called Pankos syndrome. So sometimes you have a question in the exam where a lung cancer patient presenting with these compressive symptoms. So you diagnose it as Pankos tumor. Tumors with this presentation are inoperable. You usually have to give chemotherapy, radiotherapy, and the particular symptoms associated with the compression of the individual structures I have mentioned in this table. See, if the sympathetic chain is compressed, you have Horner syndrome, myocystosis, anhidrosis, and ophthalmos. If the recurrent laryngeal nerve is compressed, you have hoarse voice, phrenic nerve, raised hemidiaphragm, brachial plexus, you have shoulder pain, arm pain, sensory loss in that distribution. If the brachiocephalic vein is compressed, you have swelling, unilateral swelling of the arm and face. So that was about lung cancer. A lot of information, but the questions that I pointed out to you, these are the questions that are commonly asked in the exam. So we'll go along with another respiratory malignancy that we have to go through. Not very common, but it's a question that is commonly asked. Mesothelioma, it's a malignant tumor of the pleural mesothelial cells, more common in males. The risk factor most associated with mesothelioma is exposure to asbestos for over 20 years. Although asbestos exposure is more commonly associated with bronchogenic carcinoma, but these patients may also develop mesothelioma over time. So what clues you will be given in your question? What are the occupations that face the risk of asbestos exposure? You can remember this. These will be the clues given in your exam. Patient will either be in the shipbuilding occupation, car manufacturing, plumbing industry. So basically shipbuilding is the most highest risk of asbestos exposure. So a patient with this exposure for a long period of time developing chest wall pain, pleural effusion, weight loss, dyspnea, you would suspect the patient to have asbestosis. So basically you have to start with an X-ray. In an X-ray, you may have peripheral lesions, plaque-like lesions along the wall, which I will show you later. You can do a CT scan. If pleural effusion is present, you might get exudative and even hemorrhagic pleural fluid, not having any other diagnosis. But to confirm the diagnosis, usually a biopsy is needed. So as you can see in this X-ray, you have this peripheral huge plaque over here in this patient with long-term asbestos exposure. The basic management is radiation. Usually chemotherapy might not be given. Surgery very rarely can be done. Prognosis is very poor. You have a maximum 2 year survival. Okay, so we have finished with the malignancies. We'll move on to another common topic of exam. It's idiopathic pulmonary fibrosis. Okay, before I start with IPF, I'll just go through two important headings from where questions are asked. One is upper zone fibrosis or upper lobe fibrosis, and other is lower lobe lung fibrosis. It's a very commonly asked question. You must remember these causes of upper lobe lung fibrosis. This is very commonly asked in the exam. And also I have given you causes of lower zone fibrosis. So there is a mnemonic to remember that: charts, poll workers pneumoconiosis, histiocytosis or hypersensitivity pneumonitis, ankylosing spondylitis, exposure to radiation, tuberculosis, of course, silicosis, sarcoidosis. So these causes of upper zone fibrosis you have to remember, and it's a very commonly asked question in the exam. The other one is lower lobe fibrosis, idiopathic pulmonary fibrosis, which we're going to discuss later. This is important. Exposure to asbestosis, drug-induced. The drug that most commonly comes in the exam is amiodarone. This one has come a number of times. The others I have listed, just go through them in case you get in the exam. But amiodarone, you must remember, is a cause of lower zone lung fibrosis. IPF is actually part of a bigger spectrum of disease. The basic disease is interstitial lung disease, now actually more commonly called as DPLD or diffuse parenchymal lung disease. Basically, there's two subheadings. One is idiopathic, where we do not know the underlying cause, and the other subset is interstitial lung disease having some known etiology, like exposure to certain chemicals, connective tissue disease like scleroderma, rheumatoid arthritis, or sarcoidosis or others. So you have interstitial lung disease, which may be idiopathic, unknown etiology, or secondary to certain underlying diseases. So this is diffuse parenchymal lung disease. What we will go through is idiopathic pulmonary fibrosis, the commonest type of this subgroup, IPF. So it is a condition where there is progressive lung fibrosis. No specific underlying cause is detected. All underlying causes are usually evaluated and excluded, typically seen after 50 years of age, affecting males more. It's gradual in onset. patients have clubbing, obviously, and bilateral basal crepitations. Fine crepitations which are not altered with coughing. So this type of bilateral basal crepitations are also seen in pulmonary edema. This type of bilateral basal crepitations also seen in bronchiectasis. In bronchiectasis, it altered with cough. But in case of IPF, it's not altered with cough. It's fine crepitations. In bronchiectasis, it's coarse crepitations. So that's how you clinically differentiate IPF from bronchiectasis. If you start with an X-ray, you might get bilateral reticular shadows, but the investigation of choice and is most importantly is HRCT of the chest, high resolution CT scan of the chest. This is the investigation of choice. You can see a lot of findings, bilateral basal reticular shadows. There may be honeycombing, traction bronchiectasis. And this particular pattern is called UIP, usual interstitial pneumonia. So interstitial lung diseases have a lot of patterns. So the pattern that is seen in IPF is UIP. Just remember this pattern. This has been asked previously in the exam. If you do a spirometry, obviously you will get a restrictive pitch feature of spirometry where the FVV1 and FVC are decreased, but the FVC is decreased more. So the overall ratio will be increased. The TLCO, the transfer factor, is also reduced. This is very commonly asked in the exam. What will be the spirometric findings of IPF? So spirometry will probably be discussed in another class. Just remember that FEV1 FVC ratio will be increased. Unlike in COPD or obstructive lung diseases, the TLCO will be reduced. And a biopsy can be done to confirm the diagnosis if the HRCT is not diagnosed. And you must exclude other causes of interstitial lung disease. In case of management, basically, symptomatically, you have to manage the patients. There are some antifibrotic agents. You can remember these two names, pirfenidone and nintedanib. These are used. To some extent, they have some role. But ultimately, these patients are even given immunosuppressant therapies and even lung transplantation may be done. The life expectancy is very poor. I have not seen any patients survive usually more than 4 years. So the prognosis is usually not very good. And there is to some extent risk of developing lung cancer in the future if the patient survives to that extent. So remember these antifibrotic agents, pirfenidone and nintedanib. Okay, let's move on to the next topic, obstructive sleep apnea. So these patients are usually obese patients who complain of apnea, periods of apnea or hypopnea during sleep. When they lie down for certain hours, the tissue around the respiratory tract, the upper respiratory tract, it compresses and does not allow air to move in. So that's when the patient wakes up with periods after periods of apnea. So usually the patients are obese. There is cessation of breathing during sleep because of the upper airway obstruction. There are periods of apnea where total respiration stops for 10 seconds or more, or periods of hypopnea where there is reduced airflow 50% or more for 10 seconds, more common in males. The most important risk factor is obesity and any cause of macroglossia. The tongue is enlarged in acromegaly, hypothyroidism, and amyloidosis. So these patients have risk of developing sleep apnea. So remember obesity and macroglossia. You can remember the others, but these are important risk factors that you have to remember. So the patient usually comes with uh, uh, the complaint by the partners, choking, interruption in sleep due to choking, and as a result, patient has morning headaches and excessive daytime somnolence. So you will have all these clues given in your question. Obese patient with all these symptoms. The complications of this condition is very important. Patient ultimately develops pulmonary hypertension, pulmonary arrhythmias, ischemic heart disease. These are the important complications. Patient even has polycythemia because of the hypoxia inducing erythropoietin secretion leading to increased hemoglobin. So the diagnosis is made by doing a sleep study or overnight polysomnography. This is the gold standard diagnostic test, doing a polysomnography or a sleep test. So you have to remember this name of this investigation. The apnea hypopnea index is seen. So the number of apneic periods per hour is used to diagnose the condition. So remember polysomnography. So the important management steps, number one, you have to lose weight. And number two, you have to give a positive pressure during sleep. It is called continuous positive airway pressure or CPAP. These are the treatment options and the first line treatment for sleep apnea, weight loss and continuous positive airway pressure. So this question is commonly asked, how to manage sleep apnea. These options you must remember. Okay, let's move on to some more common conditions in respiratory medicine. We'll discuss about pneumothorax and then pleural effusion. So you all know about pneumothorax, where the air accumulates in the pleural space. Anatomically, a pneumothorax may be closed type, where there is no movement of air in and out of the pleural space. Open type, where there is a connection with the bronchial tree, or tension type of pneumothorax, where air continues to build up. But the anatomical classification is important to know, but practically the more important classification is the spontaneous pneumothorax, where this pneumothorax is non-traumatic and the other subset is traumatic pneumothorax. This is a more practical and manageable classification of pneumothorax, spontaneous and traumatic. And within spontaneous, there is primary pneumothorax and secondary pneumothorax. Primary meaning there is no underlying lung disease. Secondary meaning there is certain underlying lung disease, like it could be asthma, it could be COPD, so on. So young patient, no underlying lung disease, non-smoker, that is primary spontaneous pneumothorax. Age above 50, smoker or underlying lung disease, secondary pneumothorax. So any of these pneumothoraces can later develop into a tension pneumothorax. So for management purposes, this classification is more important, and this is how you will be asked in the exam. Primary, secondary. The common clinical features are obviously sudden onset of chest pain, breathlessness, cough, and when a patient is done an X-ray, you will see a rim of air outside the lung margin. And for management purposes, it is important to know the rim size. If you have a rim size in terms of centimeter, it helps you to manage the patient, as we'll see in the guideline later on. Sometimes, instead of the rim size of the air in the X-ray, sometimes the percentage of pneumothorax is mentioned in the question. In that case, how you will understand the size of the pneumothorax you are dealing with, okay? So if it's given in terms of centimeter, the air column outside the lung margin, in between the lung margin and the chest wall, if you're given in terms of centimeter, then you will be able to answer, as we'll see later. But if you're given the percentage, then I have given you the equivalence. 2 centimeter margin of a pneumothorax is equal to 30%. And if it's a rim of 3 centimeter, it means a 50% pneumothorax. So we will see the significance of this in distance of this measurement later on when managing the patient. So let us go into the management steps. So first of all, when you get a pneumothorax, the first thing you have to do is to divide it. Is it a primary pneumothorax or a secondary pneumothorax? So is the patient young? Does he have any underlying lung disease? Is he a smoker? If no, then it's a primary pneumothorax. Young patient, non-smoker, no underlying previous lung disease. So it's a primary pneumothorax. So how will you measure? Do an X-ray, look at the rim. Is it less than 2 centimeter, the air margin, or is it more than 2 centimeter? Is the patient breathless or not? So if the pneumothorax is small, less than rim less than 2 centimeter, patient is not breathless. What you will do, it's a primary pneumothorax. So just discharge the patient, follow him after 4 weeks. No need for doing anything else. If the rim is more than 2 centimeter or the patient is breathless, either one, then you have to aspirate the air. You have to aspirate the air. Have you been successful? Has the rim reduced to 2 centimeter, below 2 centimeter? Has the breathless improved? Yes, then you discharge it. If not, you have to put a chest drain and admit the patient. So this is the flow chart for managing primary pneumothorax. So classify it as primary pneumothorax. Look at the rim. Is the patient symptomatic? Yes or no? So you manage him accordingly. So what about secondary pneumothorax? Patient, what about secondary pneumothorax? When do we say it's secondary? Patient is above 50, patient is a smoker, or patient has an underlying lung disease like asthma, COPD, so on. These patients have to be admitted. If the pneumothorax is less than 2 centimeter, a needle aspiration is sufficient. If it's more than 2 centimeter, you have to put a chest drain. Okay. So let's go a little bit details of this. Like I said, primary pneumothorax, what is the definition mentioned here? Age less than 50, non-smoker, no underlying disease, usually due to rupture of some apical blade. As I said, if it's less than 2 centimeter and not patient is not breathless, then discharge the patient. If it's 2 centimeter more or the patient is breathless, we do a needle aspiration. If the aspiration has been successful, discharge the patient. If it hasn't been successful, you have to put a chest drain and admit the patient. So this is primary pneumothorax, primary spontaneous pneumothorax. Secondary, like I said, same approach. If it's a secondary pneumothorax, you have to admit the patient if it's secondary. Okay. If it's less than 2 centimeter, you can aspirate. If it's more than 2 centimeter, you have to put a chest drain. If the patient is breathless, regardless of the size, if aspiration fails, for a small secondary pneumothorax, you have to put a chest drain. Okay. So less than 2 centimeter, you aspirate. You have to put a chest drain in 3 conditions. Either it's patient is breathless, regardless of the size, or it's the size is already more than 2 centimeter, regardless of symptoms, or it's less than 2 centimeter. You tried to aspirate but failed. You have to put a chest drain. Okay. All these patients have to be admitted. All these patients have to be given oxygen. So the management of pneumothorax, primary, secondary, you have to remember, because you will be given any sort of scenario in the exam and you have to write the best management or the next management. Okay. So look at the patient. Is the patient 50 years or younger or older? Underlying lung disease. Basically, first classify, is it primary or secondary? Look at the size of the air rim that has been given to you. What step has already been taken? So then answer your next possible management according to the flow chart that I have shown you. Many different scenarios may be given to you. So answer accordingly. Tension pneumothorax, the patient has severe sudden chest pain, breathlessness, and becomes cyanosed. Blood pressure starts to fall, and there is mediastinal shifting of the trachea and mediastinum. That is tension pneumothorax. Immediately you have to put in a needle and do a thoracocentesis, put a chest drain. Otherwise, you won't be able to save the patient. This is also a very common question. Following a pneumothorax, what advice you will give if the patient wants to fly, wants to travel? So the patient cannot be allowed to travel for at least 2 weeks after successful drainage of a pneumothorax following full expansion of the lung, 2 weeks minimum. And diving has to be permanently avoided. The British Thoracic Society has advised to tell the patient that they should be permanently avoiding any sort of dive. Okay, I will just take a break for 2 minutes and I'll be back with you. We still have a few more topics left. Have you all been clear with the management of pneumothorax? The chart that I've shown you? Hello, am I audible?
Yes, doctor.
Okay, so you're clear with the management of pneumothorax, hopefully?
Yes.
Yeah, okay, because you'll be given a lot of scenarios from these charts, just from this chart. So you have to answer accordingly, according to the situation of your patient. Okay, so we'll move on with the pleural effusion. Before we go into the detail, just a reminder of the causes of pleural effusion. We divided into transudate and exudate. The protein content differentiating between exudate and transudate. The protein content more than 30 grams is exudate. Common causes are pneumonia, tuberculosis, lung cancer, connective tissue diseases, pancreatitis, pulmonary embolism. You have transudates, heart failure, liver failure, hypothyroidism, nephrotic syndrome, okay, and mixed syndrome related to an ovarian tumor, right? Okay. So diagnosis of a pleural effusion clinically, after you suspect pleural effusion, after examining the patient, you go for a chest X-ray, and ultrasound of the chest is a better imaging, detecting more minute amounts of fluid than chest X-rays. So once you are successful in detecting pleural fluid, you can do a pleural fluid aspiration. You can send the fluid for study. A thoracoscopy can be done, and a biopsy, pleural biopsy can also be done to come to the conclusion and find out the underlying cause. You have to remember this criteria used for differentiating exudate and transudate. This is called the Light's criteria, where we look at the pleural fluid protein content, the pleural fluid LDH, to help us differentiate exudate from transudates. So you can remember that exudates meaning excess or extra. So all are raised. Pleural fluid protein is higher than serum protein. Pleural fluid LDH is higher, more than 2/3 the upper limit of the serum LDH. So exudate, extra or excess. Everything more in exudates. An important question that is asked regarding pleural effusion is whether the pleural fluid is infected. How do you detect that? And if you have a pleural fluid getting infected, you have to put a trace tube. So the markers of an infected pleural effusion are presence of pus, if the pleural pH is less than 7.2, if you get organisms on gram stain, if it's loculated, if despite adequate antibiotic treatment, you have poor clinical improvement. So these criteria are very important and asked in the exam. You have to put a trace drain in these cases. Okay, so some questions that are usually asked: if you have a low glucose in the pleural fluid, what does it indicate? It indicates these exudative causes: empyema, tuberculosis, malignancy, rheumatoid arthritis, esophageal rupture. So this is usually we remember it with this mnemonic: meat, malignancy, empyema, arthritis, tuberculosis. Okay, you can remember this. So pleural fluid with low glucose, pleural fluid with raised amylase, pancreatitis, esophageal perforation, both relates to raised amylase. So, and where do we get blood-stained pleural effusion? It could be bronchogenic carcinoma, mesothelioma, or hemothorax. So these may be asked in the exam, you can remember. When we drain pleural fluid, we take care that we do not drain too much of fluid too rapidly. If you do that, there is a compensatory re-expansion of the pulmonary edema to compensate the rapid withdrawal of the fluid and the change in the pressure. So after you drain the pleural fluid, if there is deterioration of the patient becomes short of breath, cough, hypoxemia following chest drain or draining the pleural fluid, this is due to re-expansion pulmonary edema. This has been asked in the exam previously. So remember, re-expansion pulmonary edema. Okay, those are the common questions that are usually asked from pleural effusion. We'll move on to another topic that is usually you might get questions from here. It's a big set of disease. These are the pulmonary eosinophilic diseases. Eosinophilic pulmonary diseases. When you have eosinophilic infiltration of the alveolar spaces or the interstitium of the lungs, this condition, the diagnosis of this condition is based on the presence of opacities on the chest imaging, number one. Number two, the presence of high amounts of eosinophil, either in the blood or the bronchoalveolar lavage fluid or in lung biopsy. So high eosinophil count with lung shadow. That is called eosinophilic pulmonary disease. What are the causes of this type of condition? There are two subsets. One where you have no known cause, that is acute and chronic eosinophilic pneumonia. Number two, when you have a specific underlying cause, aspergillosis, helminthic infections, drug-induced, uh, eosinophilic granulomatosis with polyangiitis. Previously, you have studied it as Church-Strauss syndrome, Loeffler syndrome, tropical pulmonary esophagia. Okay, so these are the known causes of pulmonary esophagia, and the unknown causes are acute and chronic eosinophilic pneumonia. So these are the causes of eosinophilic pulmonary disease. So we have to go through a few of these. We have to go through Loeffler syndrome. We have to go through tropical pulmonary esophagia. We have to go through acute and chronic. You have to remember some drugs causing eosinophilia, like I have mentioned here, drug-induced pneumonitis. So remember a few antibiotics, phenytoin, sulfasalazine. There are a huge number of drugs that can cause eosinophilia, but I feel these few drugs you have to remember. You may be asked in the exam. Trimethoprim sulfa, methoxazole, penicillins, nitrofurantoin, minocycline, any sulfur-containing drug like sulfasalazine and so on. So these drugs may be asked as causes of pulmonary eosinophilia. So we'll be discussing four of those conditions. Acute and chronic eosinophilic pneumonia. These are eosinophilic pneumonias with unknown idiopathic, idiopathic conditions. So they are acute, often less than 7 days. Symptoms meaning cough, worsening dyspnea, so and pleuritic chest pain. So any respiratory symptoms and hypoxia, chest opacities on X-ray, and presence of eosinophilia either in the blood or bronchoalveolar lavage. That helps you to diagnose acute eosinophilic pneumonia, and you are not finding any other underlying cause. So the diagnosis is based on acute symptoms, hypoxia, pulmonary infiltrates, a bronchoalveolar lavage revealing more than 25% eosinophilia, and no underlying cause has been found. This is the basis of diagnosing acute eosinophilic pneumonia. Treatment is with steroids if it's mild to moderate oral, and if it's severe, patient is in ICU with methylprednisolone. Chronic eosinophilic pneumonia, same as acute, but the presentation is more insidious, more gradual, and more than 4 weeks. The chest X-ray will be showing opacities, infiltrates, bronchial lavage will show you eosinophilia, and you exclude other causes. You have to treat the patient with more eosinophilic conditions are tropical pulmonary eosinophilia and Loeffler syndrome. Tropical pulmonary eosinophilia, we see it more in our subcontinent, in India, Bangladesh, lesser in the European countries because it is associated with Wucheria bancrofti, that is lymphatic filariasis. You all know about filariasis. The hyperresponsiveness to filaria, microfilaria in the lungs during its life cycle leads to tropical pulmonary eosinophilia. It is seen in the endemic areas. The patient will be coming from an endemic area, having paroxysmal symptoms, more nocturnal, even asthma-like symptoms. The clues that you will get is high eosinophil count, a very high eosinophil count, high immunoglobulin E, and antifilarial antibody tests will confirm the diagnosis. The treatment is for giving antifilarial drugs, diethyl carbamazine, and you manage the bronchospasm accordingly. So the diagnostic criteria for tropical pulmonary esophagia, patient will be coming from an endemic zone, paroxysmal nocturnal symptoms, even asthma-like symptoms, high blood eosinophilia, antifilarial antibodies positive, pulmonary infiltrates, and improvement with diethyl carbamazine. Basically, this is the summary of tropical pulmonary eosinophilia. Loeffler syndrome. This is similar to tropical pulmonary esophagia. The difference is this one is due to Ascaris lumbricoides, the parasite causing Loeffler syndrome. Patient has fever, cough, night sweats for less than 2 weeks. The symptom pattern is different from the previous condition. You have continuous fever, cough, night sweats for less than 2 weeks. You have X-ray shadows. You have peripheral blood eosinophilia. You can test for Ascaris lumbricoides in the stool, and you have to give antihelminthics along with symptomatic treatment and even steroids. So, Loeffler syndrome and tropical pulmonary eosinophilia are very close. So, we have gone through the eosinophilic pulmonary conditions. Our last topic for today is sarcoidosis, which is very common and one of the favorite topics to ask from in the exam. So sarcoidosis is a very interesting autoimmune disease. It is characterized by multi-system involvement with formation of non-caseating granulomas, which is characteristic of sarcoidosis. In your question, you will usually be given a clue of the patient being a Black or African descent patient because it's more common in that subset of population. And it's more common among females, young adults, more common in non-smokers, okay? And the characteristic pathologic finding is the presence of non-caseating granulomas, which may occur in any organ. Another thing is these granulomas have the tendency to produce vitamin D, 125 vitamin D, leading to hypercalcemia. So this is another cause of hypercalcemia. So this was asked in the question that why hypercalcemia occurs in sarcoidosis because of the excessive formation or production of vitamin D. So you have to remember that as well. Sarcoidosis in many cases is incidentally diagnosed. So you get a chest X-ray with typical findings, which you'll see later. Usually the patient is asymptomatic. Number two, you may get lymph nodes enlargement. You may get chest symptoms like dry cough, dyspnea. You may have extrapulmonary features. So these are the four types of presentation of sarcoidosis. What extrapulmonary features? Let's have a look of the extrapulmonary presentations of sarcoidosis. This is very important. Very commonly, skin lesions, joint pain, eye involvement. These are the commonest three extrapulmonary presentations. What will happen in the skin? There are tender reddish nodules on both the shins, symmetrical. This is called erythema nodosum, very painful. Another skin presentation is lupus pernio, pigmented, discolored plaques on the face. Patient having erythema nodosum is a very good presentation in the sense that they resolve spontaneously and it's a sign of good prognosis. Patients having erythema nodosum, they have good prognosis. Anyone having lupus pernio, it's not a good sign. It's a predictor of poor prognosis. We'll see later on the good and the poor prognostic factors of sarcoidosis. This is commonly asked in the exam. So the extrapulmonary presentations, skin lesions, joint pain, specifically, very particularly ankle joint is commonly involved. For some reason, it targets the ankle joint. Uveitis, red painful eyes, very common. So skin lesions, arterial uveitis. Other possible presentations, cranial nerve palsy, specifically facial nerve, parotid swelling, hypercalcemia, and systemic symptoms, okay? There is a syndrome called Löfgren syndrome. We'll look at it later. A little bit earlier, we went through Loeffler syndrome. This is Löfgren syndrome. Don't confuse the two. Loeffler's was eosinophilia. Löfgren syndrome is associated with sarcoidosis. So these are the extrapulmonary or systemic manifestations of sarcoidosis commonly asked in the exam. Skin, joint, specifically the ankle joint, uveitis, cranial nerve involvement, parotid swelling, Löfgren syndrome, hypercalcemia, systemic symptoms. These are very favorite questions in your exam. You can look at the erythema nodosum, symmetrical, reddish, painful, tender nodules on both the legs. This is lupus pernio. This has a very bad prognosis. Sarcoidosis is a granulomatous lung disease. So it confuses with tuberculosis, it confuses with histoplasmosis. You have to exclude those conditions. When you do an initial chest X-ray, patient having or not having any symptoms, you might incidentally find this bilateral hilar lymphadenopathy. This is a very important and diagnostic finding in sarcoidosis, bilateral hilar lymphadenopathy. This type of lymphadenopathy we may even get in lymphoma, tuberculosis, bronchogenic carcinoma. And other conditions also. But sarcoidosis is the commonest cause of this type of bilateral. This may be anything on a chest X-ray. No need for any details, but the gold standard for diagnosis of sarcoidosis is biopsy. Any sort of biopsy, whether it could be lungs, it could be skin. If you get a non-caseating granuloma, it is diagnostic of sarcoidosis. Regarding this is something that is very important, and it's because of increased production of vitamin D. So if you do a spirometry, obviously you will get a restrictive pattern of lung defect, that is decreased DLCO and increased FEV1 FVC ratio. Sometimes you can get ECG findings of a prolonged PRR interval because of cardiac sarcoidosis, very rare. Bronchoalveolar lavage mesolymphocytosis, and this is an important investigation. There is raised angiotensin converting enzyme levels. It helps you to add to the diagnosis, but it is more important. It has a more important role in monitoring disease activity. So this is an investigation that is specifically done in sarcoidosis. We don't do it anywhere else. Like I told you, there are a lot of causes of bilateral hilar lymphadenopathy, histoplasmosis, HIV, berylliosis, silicosis, and so on. Just for your interest, I put these causes down. So how do you treat sarcoidosis? If it's mild, patient is symptomatic, you don't need to do anything. So patient is usually remits without treatment. In 2/3 cases, patients resolve and there is no further need for any sort of intervention. If patient is having moderate to severe disease, then you start with prednisolone. This is a very important question, a very favorite question. When to use prednisolone in sarcoidosis indications? Patient having lung involvement, parenchymal lung disease. If the parenchyma is involved, you have to give steroid. If there is hypercalcemia, you have to give steroid. If there is uveitis, you have to give steroid. If there is cardiac involvement or neurological involvement. These are the 5 indications of using steroid in sarcoidosis: parenchymal lung involvement, hypercalcemia, uveitis, cardiac or neurosarcoidosis. Very, very important question for the exam. MTX is sometimes used, infliximab is sometimes used, lung transplantation rarely done. So use of steroid is important for you. We were discussing the prognostic factors for sarcoidosis. As I mentioned, you have to remember the good and the bad prognostic factors. So there are 2 syndromes associated with sarcoidosis. A little earlier, I told you about Lofgren syndrome. It is a variant of sarcoidosis having an acute presentation with arthritis, typically the ankle joint involvement, erythema nodosum, bilateral hilar lymphadenopathy, and fever. It's a syndrome having an acute presentation and a very good prognosis. It's self-limiting, occurring in younger patients. Another syndrome, Hilford syndrome, it's another variant of sarcoidosis with chronic presentation. You have parotitis, uveitis, facial palsy, fever, more chronic presentation, and it does not have a very good prognosis. So 2 syndromes commonly associated with sarcoidosis. Thank you very much. We've covered a lot of topics today, and I've tried to point you out the common questions that are asked that have appeared in recent exams from these topics, and I hope it has been useful to you. And you're all welcome to ask any questions from any topic, basically.
I mean to say, yeah, classification of lung cancer
Yeah,
and related with the staging and chemotherapy.
yeah.
Which stage will
Which what chemotherapy
Right,
is like?
right. You're talking about the treatment and staging, right?
Treatment and staging.
I think you're talking about these two slides probably, right? This is
Yeah.
small cell lung
Classification
cancer.
of
Yeah, small cell lung cancer classified as limited disease and extensive disease. In some
yeah.
cases, early stage. Early stage to diagnose small cell lung carcinoma, very rare. Surgery done in
Nice.
that case, but usually once small cell is diagnosed, it's usually limited disease or extensive. You answer chemotherapy plus radiotherapy. This is the common
This
treatment protocol for small cell
in,
lung cancer.
in early stage.
Yeah, this is both cases. In both cases, we are giving chemotherapy and radiotherapy. Just the combination duration of the chemotherapy is different. The radiotherapy is different. That's it. But the answer for small cell lung carcinoma is chemotherapy and radiotherapy.
Okay.
In
Oh,
non-small cell lung cancer, you have a chance of surgery up to stage 1 and 2. In 3 and 4, in 3, you give chemo radio. In 4, only chemo. That's all you have to remember.
And in
usually,
latest chemotherapy, which one we use?
Sorry?
Latest chemotherapy, which one we use?
Oh,
In preference.
chemotherapy, I have given a list of the chemotherapy. Now, a lot of tumor markers have come up. So we
Okay.
send those tumor markers, and according to the marker that's positive, the chemotherapy is selected. I have given
Oh,
that. Usually that much of detail is not asked, but for your interest, I have put it in the slide here below. The systemic, is
systemic
EGFR,
anti-cancer
TK,
therapy.
yeah,
Yeah.
right. ALK, PDL1. So these markers are sent as a panel, and
Okay.
according to the positivity, the selective chemotherapy is given. So that's actually, you may get these questions in your part 2, but usually not asked in part 1. That's okay. That
Okay.
too very
Fine.
rarely.
Fine.
Yeah.
Fine.
But
Fine.
this
usually,
is, yeah, please.
may I ask a question? Usually, do they discuss extensively on staging of cancers, like
No,
what
no,
is
no,
the
no,
involvement?
no, no.
No.
You do not
Okay.
need extensive knowledge of
Thank
staging. Just this is a common cancer for bronchogenic carcinoma specifically. That much you will need to know. That stage 1 and 2 surgery, stage 3 chemoradio, stage 4 chemotherapy. In other cancers, very rarely asked.
Okay. Thank
Mm.
you.
So one
Sir,
question.
Sure.
yeah.
Sir, that you have mentioned that the contraindication for the surgery in the lung cancer, that malignant pleural effusion. Sometimes the patients come with the minimal pleural effusion, and
Yes.
we are not finding any exudate kind of things. It might be like malignant pictures showing the thing. So, is it a minimal pleural effusion is also the contraindication for
No.
surgeries for lung cancer?
You must prove that it is malignant. Pleural effusion in bronchogenic carcinoma may be reactionary. So if
Yes,
it's the case, you can go for surgery. Just you have no other evidence of metastasis, just minimal pleural effusion. No. But if it is proved to be malignant, that is hemorrhagic, or you have exudation, malignant cell found, in that case, it's contraindicated.
sir, and then you told that ARDS may alveolar arterial
Yes,
oxygen
yes.
gradient is
Right.
normal. That
Correct.
is type 1 respiratory failure, no, sir?
Yeah,
That
right.
is for type 1 respiratory failure.
Yes,
That
yes,
all the criteria for the type 1
yes,
respiratory failure, no,
yes,
sir? Am I
yes,
right,
yes,
sir? Like
yes. Yeah.
hypoxia, low PO2, and
Yes,
PCO2 is normal or low, and
yes,
PO2 is increased.
right.
And the same thing is type 2, that PO2 of this normal.
Yeah,
PO2, alveolar arterial oxygen gradient is
will
in
be raised.
normal in the type 2 respiratory failure.
Right.
Isn't it, sir?
Yes, you're right. And you asked about the
Yeah, Lambert return myasthenia
Lambert
gravis
syndrome.
normal.
Okay, I will tell you clinically how to differentiate.
Yes, sir. Yes, sir. Please.
Number one, when the patient is in front of you, you ask for the pattern of weakness. In myasthenia
Yes,
gravis, the patient will become progressively fatigable as the day goes on. In
yes,
Eaton Lambert syndrome, he will have similar symptoms, but if he goes for some sort of exercise or some sort of strenuous work, initially there will be improvement in muscle strength. After that, he will become fatigued. The pattern of
okay.
weakness is a little bit different. Number one. Number two, the pattern of muscle involvement is different in both. You will have ocular bulbar involvement in myasthenia gravis. You will have drooping
Yes,
of the eyes. You will have dysarthria, hoarse voice. In
yes.
Lytton-Lambert syndrome, it is more of proximal weakness. The thighs and the arms will be weak, not the bulbar and facial involvement. Okay.
Okay, sir.
Okay. Number
Yes.
3, very important. Reflexes will be intact in myasthenia gravis. If you see Eaton-Lambert syndrome, you will have reduced or absent reflexes. These 3 clinical points will help you differentiate the 2 conditions.
And the test, what we have to do, sir? Hydrophonium test, tensilon
Yeah,
test.
there is a tensilon test. It will be positive in myasthenia, but not in Eaton-Lambert. But clinically, that type of history in an elderly. Oh, another thing is the patient will be elderly smoker in Eaton-Lambert syndrome, and it's usually a young patient with a thymoma in myasthenia gravis. So you will have a lot of clues to differentiate both.
Yes, sir. Yes, sir. And sir, for suspecting sarcoidosis, what blood test and what investigation we have to send initially?
Uh,
Like so many tests is mentioned, sir. Like
yeah. Like I said to you, man, when you have
X-rays, you have
when
shown
you
the
have a
X-ray.
yeah when you have a patient with respiratory symptoms, you do an X-ray. When you get bilateral hilar lymphadenopathy, that is the first point when you suspect sarcoidosis. Number 1, no one suspects sarcoidosis initially. Okay, it's
Yes,
very
sir. That's why.
yeah. So either you have to get a erythema nodosum, or you get
Yes,
a
sir.
lupus pernio, or you
Lupus
get
pernio.
a bilateral hilar lymphadenopathy, or you will get a
Yes.
facial palsy.
Or
Okay.
Hayford syndrome, like
Yeah, or
parotic
you will get an
tendency.
incidental hypercalcemia for some reason. If you
Instead
get
of that.
these, then you suspect sarcoidosis. Otherwise, it is not possible to diagnose sarcoidosis just from symptoms.
Yes,
Okay.
sir. You're right. And sir, सर डीएलसीओ वाला कैसे टेस्ट करते हैं सर यू हैव मेंशन समथिंग इन interstitial lung disease that
Yeah.
about the DLCO.
Hmm.
How to do this test, sir? Can you just elaborate, please?
It is a part of the spirometry. DLCO means how much of oxygen is being able to be transferred from the lungs to the capillaries, to the alveolar, to the arterial blood.
Yes, sir.
That ability is signified by DLCO. So just like spirometry, I think there is a machine where you have to blow into it, and the reading in the will show the DLC or the TLCO. It will show you the level of the
Yes,
TLC.
sir.
Yeah. So that's how you basically get the reading.
Okay. And that for this superior vena cava syndrome, that
Yeah.
radiotherapy
Yeah.
and prednisolone, you have given the options, sir. Can you just show the slide again, please?
Sure.
Because it is my full question, sir. I am in critical care.
Yes, that's an important subject also for the exam.
Yes, sir. For me, I would just want to take a snap.
Sure. Superior vena cava obstruction, right? Yeah. Okay.
Yes, sir. It's my long question. Like,
Sir, one question.
Sure.
Suppose a patient, female patient with adenocarcinoma, it is usually in peripheral part.
Yeah.
And the symptoms are not prominent initially.
Right.
But FEV1 is not less than that 1.5, but only 1.5 to 1.8. In that case, is surgery indicated?
I didn't get the last part of your question. Adenocarcinoma, peripheral lesion, and then?
Yes, peripheral lesion, but
Yeah.
the symptoms are not so much prominent that it indicates that adenocarcinoma, it supports adenocarcinoma. But
Okay.
FEV1 is 1.5 to 1.8, not less than 1.5.
Okay.
So then whether it is indicated, surgery is indicated or not?
So symptoms does not guide your treatment. Totally depends on the staging. If there is no contraindication to surgery and the patient is in stage 1 or stage 2,
Okay.
according to this slide, you can go for surgery immediately. So, okay. If there is any form of unilateral or distant metastasis, that is stage 3 or 4, you cannot do surgery.
Okay, that is similar for all lung cancers.
All non-small cell lung cancers have the same treatment modality.
Okay.
Squamous cell, adenocarcinoma, large cell. You follow this protocol.
Okay, thank you.
Thank
so
you.
one question from your pneumothorax, BTS guideline you have told that less than 2 centimeter, more than 2 centimeter. How we come to know in X-rays? Can we come to know what we have to do the HRCT to diagnose that less than 2 centimeter, more than 2 centimeter, like whatever the protocol you have given according to the BTS guidelines?
Uh, Did you ask how to measure the rib?
Yes,
How
sir,
to
because
measure the rib? Actually, for some reason, I forgot to put that slide in here. I have an X-ray labeled how to measure the rib. Okay. Uh,
because I am always
just
forgetting things.
just
I
from the chest wall, up to the collapsed lung margin. Okay. You just measure the distance if it is with a scale, if it's more than 2 centimeter or less than 2 centimeter.
We
The-
usually do this in our ICU.
yeah. So that is
Yeah.
a very practical guide to measure the air column. Take a decision how you're going to manage the patient. Okay, so let me show you this one slide. If this is an X-ray, so you measure the distance in the X-ray from the lung margin. Sorry, from the lung margin up to the collapsed. From the collapsed lung margin up to the chest wall. This is the thing we measure. Is it less than 2 centimeter or more than 2 centimeter? Lung edge and chest wall. That is all. That is all you need to take a decision.
Okay.
Okay.
Sir, one question again.
Sure.
That can you elaborate the ARDS pathophysiology once and
Oh, sure.
what's the ventilator settings will apply initially
Okay.
with respect
Okay.
of PEEP and as well this tidal volume effect and everything.
Sure. Okay. The pathophysiology basically, when you have any pulmonary or extrapulmonary condition where there is extensive tissue damage, there are release of a lot of inflammatory mediators locally. So these mediators cause migration of neutrophils in the circulation. And when these neutrophils reach the alveoli, these neutrophilic mediators affect the alveoli and the surrounding the structures. A lot of cytokines, proteases are released. So it leads to damage of the alveolar membrane on one side and the alveolar epithelium on one side and the alveolar capillaries on the other side. Both the structures are damaged. A lot of exudate is formed in between. And the
In the
hyaline
intestine.
membrane is, a lot of exudate, which later forms a hyaline membrane, and it disturbs the oxygen exchange in that area. Okay.
This accumulation in the interstitium or in the alveolar
In the
space?
interstitium and on the alveolar surface, as you can see in the
Both.
pathophysiology, in both areas, interstitium and alveolar surface. Both places.
And what is that in just last one line before the last line? That is oxygen derived some chemicals. What is that?
Okay, let me see.
Before the last line.
Okay, I'll just check.
In the pathophysiology. Reactive oxygen species. What is that?
Oh, these are probably free radicals. As a result of all these cytokines, like a cytokine storm, like we saw in COVID. Yeah, so a lot of chemicals, including free radicals. They are all toxic for surrounding structures.
And can you tell little about this ventilatory settings regarding PEEP and other things? When a patient comes initially with ARDS, the initial settings of the ventilator settings would be, what will be the indicators how to set the ventilator?
Okay. Because here the when you want to increase the oxygen saturation of the patient, either you have to increase the FiO2 or you have to increase the PEEP. By increasing the FiO2, there is no use because of this hyaline membrane that's been formed. By increasing the percentage of oxygen that you are supplying to the patient, it usually doesn't help that much. So you need to use a little bit of more PEEP. You need to increase the pressure to allow a little bit of more of oxygen to diffuse through that area. So you do not change the FiO2. You use a low tidal volume setting and a little bit of high PEEP. So basically, that is what I told you to remember. The two main ventilatory modes that you use is a high PEEP and a low tidal volume ventilation.
And sir, what about the rate? Rate also should be increased.
Yeah, you can increase.
Sir, one question. ARDS, which ventilatory mode is good, sir? Volume control or pressure control, or we can put anything?
Yeah, that will depend on the situation of the patient. Yeah, usually use a low pressure. Pressure should be a little bit low because uh, the compliance of the lung is a bit low. So if you use high pressure, it will lead to barotrauma. So a little bit of low plateau pressure is used. So that is one more criteria. So
So
you use
which mode we can use, a volume control or pressure control? Like, is there any difference between volume control and pressure control
no,
in
you
the
use
terms of the
pressure
ideas?
control. You can use the pressure control because
Sir, how
volume
much
you have to use
maximum
a
peak we can go, sir? Like high peak, low tidal volume. It's a
yes.
recruitment. We used to sort it out daily, like high peak, low tidal volume. How much peak we can increase this, sir, according to the arsenic trial? If you have come across this arsenic trial and placebo trial, they have made them one according to the standard body weight, like ideal body weight. They have made a tidal volume. So how much peak we can go and how much tidal volume maximum we can put, like, sir?
Okay, that I have to look into a bit, but we have to take care of not putting excessive pressure because very low compliant lungs in ARDS. We saw that in COVID also. So a lot of patients had developed barotrauma. So we have to,
That is my 15
yeah,
marks questions at this
yeah,
ARDS. It's a
yeah,
big topic for me,
yeah,
sir.
it's a
That's
very
why
important
it is
topic.
more
Yeah,
like, yes, sir. If you can put next time, if you can
yeah,
show any slides for this thing like arsenic trial and placebo trial, they have make one
that's
chart,
right.
sir. According to that, you can put a tidal volume and you can put a peep. But how much maximum peep is allowed? We cannot go up to 20, sir, that peep. And we cannot, like high peep is okay, but we cannot go up to 20. And there is a respiratory rate also, there is a parameter like
Yeah.
35 per minute. But
Okay.
how to titrate this thing? Can you just elaborate in the next class? It will be beneficial for my
Okay.
final exam.
Sure. Actually, this ventilation is a separate class and different
Yeah.
conditions. Yeah, it's a very big topic.
Prone position ventilation and
Yeah.
also pharmacy
Yeah,
has
yeah. A lot of things involved here. So if I get a chance, I will discuss with this in another
This
class.
ARD is also known as shock lung, na, sir? Yes, sir. Na? Am I right, sir? Hello.
Hello? Yeah.
This
Can you hear
ARD
me?
is also known as shock lung, na, sir? Shock lung.
Hello?
Hello. Am I audible, sir?
Sorry, yeah. You're getting cut off. Sorry.
Sir, this ARD is also known as shock lung, na, sir?
Sorry, I couldn't hear you. ARDS also known as?
Shock lung, shock
Sure,
lung.
sure.
Synonyms that. Hello.
Yeah. Hello? I couldn't hear you.
Sir,
Synonym for ARDS?
name for,
Sir,
yeah.
sir, actually is telling that ARDS is known as shock lung.
Oh, another name is acute lung injury. ALI.
lung injury. Sir, COVID
Hello?
ARDS is a bit different from this type of ARDS because in COVID we have seen that high peak has a very detrimental effect on lung.
Yes, that initially at the start of COVID, high PEEP was used. Later on, the PEEP was reduced and a lot of the mortality was reduced significantly. So it's a bit different, the COVID ARDS. That's right.
Sir, last one question. There is there any role of lasix in ARDS?
Not really.
Sometimes we got some
Yeah,
help
yeah.
by using
You can
lasix.
use diuretics, but there is one
So,
slide here. I have shown you, there is one slide. I did not say it, but I wrote it down. Usually, diuretics are not that effective because the infiltrate is inflammatory. It's not edema. So diuretics are less effective. But these patients develop associated pulmonary edema at times.
Yes, it is
yeah,
So yeah, in that case, you give diuretics, judging the
sometimes
patient's
we got
condition.
some
Yeah.
help from
If
in
you say
such.
diuretics do not very specifically help.
Sir, recently in our also we use the lasix.
Okay.
One of the patient
Yeah.
got ARDS,
Okay.
and
Yes.
he successfully came out from the
Yes.
ventilation. It
Yes.
is near about 1 month. He's on ventilator now in portable ventilator Wi-Fi.
Okay.
He's totally fine, but still, lasix we ran around 7 days to get him
Okay.
negative balance. Then
Yeah.
we got associated with
Yeah.
steroid
Yeah,
and
you can use.
antibiotics and other
You can use.
things.
Definitely. We are using diuretics. Definitely. Yes.
Okay, sir. Thank you. Sir. Thank you.
Okay.
Good night.
The
Okay.
glucocorticoid role, you have written that it's not useful, but we used to give the glucocorticoid in AIT's protocol. Sir, will it change the morbidity and mortality in ICUs for the ARDS patients? Like,
This statement is written in the book I took it from, but recently the role of steroids in ARDS is increasing and more trials are coming up where it is showing that they may reduce mortality in patients with acute ARDS. So, and we are using this actually. We are using
what
for
are you
diabetics,
using,
we are
sir?
using steroids. Yeah.
You are using dexamethasone or you are using methylprednisolone? So what you are
So,
using? Any price?
uh, we use dexamethasone a little bit more.
Okay, thank you.
Thank you.
Very happy to talk to you, sir. It will be helpful for my curriculum.
Yeah, all the best for you all. And
Thank
it's
you.
been a pleasure taking a class for you all. I've completed GIT with you. I've completed this class of respiratory medicine with you. I've
And
been
just
assigned
tell
these
me
two
what will
chapters.
be the next topic for your this
Well,
respiratory medicine?
I have been given these two topics only, GIT and this half of
Okay,
respiratory
okay,
medicine. So I'll be glad to have given any other topic.
Thank you.
okay, okay. Thank you.